A very good morning to everyone. So today we'll be presenting the CGR from our department, and we'll be discussing certain clinical conundrums or certain difficult cases in oncology. So before I begin, a brief introduction to the department. The department was started in February 2021. At present, we have 12 general beds, 3 semi-private and 3 private beds. Our ward is shared with radiation oncology. We have a daycare center in the first floor of AIIMS department and the PMR daycare, where our patients receive chemotherapy and transfusion support on a daily basis. Our solid tumor OPD, which is run by Dr. Pramod Kumar, runs from Monday to Friday. The Hemato-Oncology OPD is run from Tuesday, Thursday and Saturday. The OPD footfall per month is approximately 1500 per month. The IPD admissions are approximately 70 to 80 per month, and the daycare admissions almost go up to 1000 per month. So with this brief introduction, I'll start with the first case. So this was a 67-year-old male having no known comorbidities. He was a chronic smoker and a farmer. His chief complaints were of a blackish plaques which were covering over the whole body for past 3 weeks. He had presentation of fever and cough with expectoration for 7 days. And he also developed intermittent low-grade fever associated with a swelling in the right axillary region along with hemoptysis. For this, he sought treatment at a nearby hospital, and certain antibiotics and antifungals were given from the practitioner there. So his LRTI and hemoptysis improved, but the skin lesions were progressing over a time, and hence he was referred to our institute. So this is the photograph of the patient, which has been taken with the due permission. So at presentation to us, he had a good performance status. He had no pallor, icterus, cyanosis or clubbing. There were palpable lymph nodes in the bilateral axillary region, with the largest on the right side, which was approximately 2 into 2 centimeter. The systemic examination was normal, and there were presence of certain blackish patches and plaques of various sizes over the forehead and all over the body, including his face, the chest, the abdomen, the hands. And this, you can see, this was the largest plaque which was present, almost 7 into 4 into 1 centimeter in the right hypochondric area. So he had got certain investigations also done outside, which was suggestive of a hemoglobin of 8 gram% with a high TLC of 38,000, and platelet counts were 67,000. His peripheral smear showed presence of thrombocytopenia along with certain atypical cells, the nature of which was not known. And the FNA also showed presence from the right axillary swelling, showed the picture of either some lymphoproliferative neoplasm. His liver and kidney functions were normal. So we kept a provisional diagnosis of leukemia or lymphoma given the skin lesions that were present, and or it could have been a lymphoma in the leukemic phase. So he also had a baseline investigation in the form of the CT, thorax and abdomen, which showed multiple nodes both above and below the diaphragm. And there was also cavity with consolidation in the right upper lobe, which was suggestive of the fungal pneumonia, which was in the healing stage, for which he had already sought treatment outside. So with the background of the atypical cells in the peripheral smear, we performed a bone marrow examination. And here the marrow showed the infiltration by the blasts. And on the IPT, there was, which was done by flow cytometry, this was suggestive of presence of the blast, which was CD10 positive, CD38 positive, HLA-DR, CD56 and CD123 positive. CD4 and CD7 was also positive, but other B cell, T cell and myeloid markers were negative. So this was not fitting exactly into a particular type of leukemia. So what next? So we decided that he has the other skin lesions which are present, and with the help of the dermatology consultation, we also got a skin biopsy done. And here in the skin biopsy, there were presence of CD4 and CD56 positive blast cells. And then it was commented that the patient was having a blastic plasmacytoid dendritic cell neoplasm. So you can see here in the skin biopsy, there was infiltration by the blast. These are the blasts, and also with the CD4 positive staining, which was found in the subcutaneous tissue. So our final diagnosis was that of blastic plasmacytoid dendritic cell neoplasm in the leukemic phase. So for this patient, we started him on an ALL-like chemotherapy regime, which is the BFM 90. He was given induction in May 2022. At the end of 4 weeks of induction, the patient achieved a remission in the bone marrow, which was at day 36. There were no blasts. And we also, in addition, did a CSF analysis, and this was found to be negative and for malignant cells, and he was given continuous intrathecal methotrexate prophylaxis. After induction 1B, which was in June and July 2022, he was stable. But in the next phase, where we were supposed to give the consolidation with high-dose MTX, after the second cycle, he developed grade 4 mucositis with febrile neutropenia and the flaring of the fungal pneumonia that he previously had. So he had to be admitted for a long time, almost 3 to 4 weeks he was admitted, and was treated with the antifungals and growth factor support. The patient recovered clinically, and after that we started him on the maintenance using 6 mercaptopurine as well as weekly methotrexate, which was in the oral form. And at the last OPD visit, this patient was asymptomatic and continues to be in remission. So just to illustrate how with the treatment the patient's condition improved, like I had shown previously at presentation, there were multiple lesions, and with the therapy the skin lesions also improved. So the take-home points for this case are that the blastic plasmacytoid dendritic cell neoplasm is extremely rare. It's almost just 0.4% of all the hematological neoplasms and just 0.7% of all cutaneous lymphomas. And 80% of them will present with skin lesions. So what we learned from this case is that it is important to do a skin biopsy with the IHC, which is essential for clinching the diagnosis. So you need to know about this entity so that you can arrive at the correct diagnosis and treat the patient accordingly. It has a male predominance, with the ages presentation being between 65 to 70 years, and it basically arises from the plasmacytoid dendritic cell, the type 1 interferon producing cells. However, the optimal management is basically the CD123 targeted therapy. So like I had shown, the cells, the blastic cells in this patient were CD123 positive, but this is not available in India. So we have to do with the treatment like the ALL regimens along with the CNS prophylaxis. And another challenge faced with this patient was that intensive chemotherapy for this kind of population is difficult to administer, and it is challenging, and you are faced with multiple problems in such patients. I'll come to the second case. So this was a difficult case. It was a 26-year-old female who was in the antenatal 27th week of period of gestation. She was third gravida, para 2, having 2 live children. She had ecchymotic patches over the lower limbs, along with complaints of epistaxis and shortness of breath for the past 7 days. Till 26 weeks, she was okay, but in the 27th week, she presented with that. And her previous pregnancies were uneventful. However, her past treatment history, we found that after the second delivery, 3 months postpartum, the patient was diagnosed as a case of T-cell acute lymphoblastic leukemia in September 2020, and she was treated for this particular entity at some other center. And once she had achieved remission, she was started on the maintenance treatment, but she defaulted the therapy in January 2022. And this was the time, this was nearly November 2022, so almost 10 months after this episode. So at the time of examination, she had tachycardia and severe pallor with the PET EK. There were palpable nodes seen in the bilateral axillary region. On systemic examination, she had a splenomegaly of 3 centimeter and her fundal height corresponded to 22 to 24 weeks. So our provisional diagnosis at this time was acute leukemia in pregnancy with a relapse, because her treating obstetrician, when they got her investigations done, she had a hemoglobin of 6.1 gram %, a TLC of 4.5 lakhs and a platelet of 14,000. So imagine this pregnant female, she's 27 weeks pregnancy and she has a TLC of 4.5 lakhs. So she was immediately in an emergency, she was sent directly to the medical oncology department. So at our center, her peripheral smear showed presence of 88% blasts. Her uric acid was also raised. This is a marker for tumor lysis. And on the immunophenotyping, it was found that the cells were positive for CD45, CD38, CD4, CD5. These are the T cell markers, CD7 and CD8. So this was clearly a case of T cell acute lymphoblastic leukemia in a relapse. And on the antenatal ultrasound, the baby was 27, the fetus was 27 weeks period of gestation. There was adequate liquor and the fetal weight was around 950 grams at that time. So our next step was, when we were faced with this difficult case, we had to do a lot of counseling with the family members. And they were counseled and basically explained regarding the risks to both the mother and the baby at this time, and what was the importance of the treatment. But along with the treatment, they were explained, because this was a relapse, it was not a de novo case, that they would have to basically be prepared for any kind of morbidity or mortality that could occur. There were multiple rounds of discussion with our obstetrics team, including Dr. Garima and Dr. Priyanka. Very thankful to them. So they basically with this we decided that at this point, because the baby was healthy but still 27 weeks of gestation, we planned the patient to give an intensive salvage chemotherapy, because this was a relapse case. And the plan was that we would give this therapy. So after nearly 3 to 4 weeks, once the count recovery would start occurring, it would already be week 32 to 34. And then we would be able to do a successful delivery in this patient, provided that the interim period, the patient and the baby remain all right. So this was the treatment that we gave in our ward. And as you can see, there are so many drugs. All of them are cytotoxic. It was cyclophosphamide, very high doses, doxorubicin, vincristine, steroids, and the intrathecal prophylaxis was also given in this patient. So regular obstetric follow-up was done for this patient, and luckily by day 21, the patient's hematological parameters started to recover. She developed febrile neutropenia, but for that we managed her well with the antibiotics. Luckily she did not develop any hypotension, and we had to we kept her in an isolation room. And she basically there was an improvement in her counts. There were no very serious adverse complications. And we did a bone marrow aspirate and biopsy at day 25, and the patient went into remission. So our treatment was a success. And the antenatal ultrasound at this point was nearly 30 plus 2 weeks of gestation, and the fetus also had gained weight, and it was now 1.6 kgs. And at 32 weeks of gestation, the patient was given the steroids for fetal lung maturation. At 33 weeks of completed weeks of gestation, the patient underwent an LSCS because it was a breach, and fetus or live male baby of 1.6 kg was delivered. The neonate required the NICU stay for approximately 2 weeks in view of low birth weight as well as mild respiratory distress, but later was discharged. The patient's post-op recovery was uneventful. The baby was healthy and feeding well. We could not give breastfeeding to this baby because the mother had already received cytotoxic chemotherapy. So after the delivery, when the stitches were removed, her chemotherapy was resumed. And at last visit in March, the patient continues to be in morphological remission and is on chemotherapy. So the take-home points from this case is that the incidence of leukemia in pregnancy is very less, but the morbidity and mortality is very high. The approach to the management remains a substantial challenge. And in these patients, after 20 weeks of gestation, bridging chemotherapy without methotrexate can be given until the third trimester can be instituted. And the elective delivery after 32 weeks can be planned while aiming to avoid any pancytopenia during the delivery time. And most importantly, such cases, they require multidisciplinary teamwork with a combined decision making from the hematologist, the obstetrician, and the neonatologist for the better patient and neonatal outcome. So with that, now I'd like to call upon Dr. Pramod. He's my colleague. He'll discuss the other cases.
Good morning, senior faculty members and dear friends. I will be discussing two cases. My first case was, she presented to us in November 2020. She was a 55-year-old female, non-smoker without any medical comorbidities. Her presentation was with acute onset shortness of breath, and there was bilateral pleural effusion on HRCT. That was the COVID time, and she was initially managed on the line of COVID. Later, the pleural fluid cytology was done, which has turned out to be positive for malignant cells. Then subsequent evaluation, the final impression was that it was an adenocarcinoma lung with metastasis, and she was started on chemotherapy. However, on interim assessment, there was a progression of disease, and at this point of time, patient mutation panel report was available, and it was found that patient is having EGFR exon 19 deletion mutation in the lung with TPS score 0. She was started on the TKI, which is osimertinib, and she was on follow-up, and the disease was well controlled till August 2022. At that point of time, there was evidence of progression. However, clinically, patient was very stable. We confirmed the progression on CECT, and we did another biopsy. Since the disease was there only in the abdomen as a omental deposits and caking, so we had a possibility that this could be a second malignancy because there was no disease in the lung, in the thorax. However, the biopsy from the omental nodule again confirmed that the disease is primarily the adenocarcinoma lung, which was confirmed by the IHC panel. Now, at this juncture, patient was offered a second-line chemotherapy and a comprehensive NGS panel. Because of bad experience of chemotherapy in past, patient refused to take second-line chemotherapy, and she want to wait for the NGS report whether any other targetable therapy can be administered to her. Meanwhile, patient presented in the emergency with acute onset shortness of breath. Her CT pulmonary angio report as acute pulmonary embolism. She was admitted in the ward and she was stabilized. Anticoagulation was started, and after clinical improvement, patient was started on second-line chemotherapy with a combination of nab-paclitaxel, carboplatin, and bevacizumab, and it was administered on weekly basis. And when the NGS panel, the comprehensive lung panel came, it shows that there was a loss of mutation which was earlier present, and no new targetable mutation was found in the panel. However, we have started the treatment on time, and at present patient is completing her third cycle of chemotherapy. She came to OPD in walking. She's fine, ambulatory and fine, and she's planned for a response assessment in the third week of April. So, in this case, we have noticed that the outcome of our patient was consistent with the original osimertinib trial. Our patient progression-free interval was 15.5 months, which was very well within the confidence limit of the FLORA trial. So now this patient have relapsed on our third-line anti-EGFR therapy. So what are the potential mechanisms for relapse? So these mechanisms are either EGFR independent mechanism, that means there is appearance of new mutations in other pathways, or there is a histological transformation from non-small cell to small cell, or there are appearance of gene fusion mutations. And there are certain pathways which are EGFR dependent. It means there are new mutations which come in within the domain of EGFR. And these most of the NGS panel do not test these mutations because there is no therapeutic option available for these mutations. So these are the EGFR independent pathways. So there can be a crosstalk between MET, HER2, IGF, FGFR, and these are the EGFR dependent mechanisms in first line and second line osimertinib. So take home message that neotherapeutic agents bring new challenges, and it is very important to understand the underlying drug resistance or tumor escape mechanisms. My next case will be a case. The patient was a resident of Jodhpur. How he was consulted TMH hospital, and he was a 52-year male presented with complaint of epigastric pain, anorexia, weight loss. Her upper GI endoscopy was polypoidal mass lesion at lower end of esophagus, lesser curvature of stomach, which was reported as carcinoma GE junction. And on CT scan for staging, there was a lymphadenopathy up to retroperitoneal lymph node, which makes it inoperable upfront. So patient was deemed as metastatic poorly differentiated adenocarcinoma. The FISH for HER2 amplification was negative, and he was tested for PDL1 and the CPS score was 85. So the final impression was metastatic adenocarcinoma of GE junction. Patient planned for chemotherapy, and 6 cycle of flawed protocol was planned, and the treatment was given at our centers, and the response assessment after 6 cycle was complete metabolic response. Again, the patient consulted the TMH team, and at this point there was a discussion between whether to go for surgery because there is good disease control, or patient requires some maintenance therapy. So the final plan was to give maintenance immunotherapy with nivolumab for at least for 2 years, and the opinion was that if the disease doesn't progress within 2 years, then they will consider the patient for surgery. So the treatment was delivered at our center, and on serial monitoring, till date there is no progression of disease. Now at almost 26 months on treatment, and patient has gone for review at TMH. So these are the two main studies which has established the role of immunotherapy in gastric or GE junction cancers. And why there is a figure of 2 years? Because the maximum evidence of use of immunotherapy is with 2 years. We don't know whether we will benefit after using beyond 2 years. Now, should we operate this patient, and what will be the time of surgery? The original FLOT trial, which was done in metastatic stomach cancer, the median PFS was 6 months. And however, there is a growing evidence that surgical resection could be possible among the patients who are less than 70 years of age with with one site of metastasis, patient with one metastatic site, nodal or liver, or there is an excellent response to systemic therapy, which fits in our case, and patient with metastasis limited to liver, which seems resectable. And this trial is the ongoing trial with in Germany from the group which has developed the FLOT protocol, and they are trying to answer whether these patients should be resected or we can go for follow-up after chemotherapy. Again, the immunotherapy is the take-home message from this case is that immunotherapy is expanding the scope of treatment in cancer, where overall survival initially was originally in months, and patient treatment tailoring requires a great understanding of the topic, and we may not get all answers from the available guidelines and the trials. So regarding the department, these are the ongoing projects at present. So there is a non-funded research on the quality of life assessment in adult patient with hematological malignancy. We have started enrollment in this patient. The another trial is in collaboration with the Surgical Oncology and Radiation Oncology Department. This is a multicentric study, and it is regarding the whether neoadjuvant chemotherapy followed by surgery versus surgery followed by adjuvant chemotherapy, which is the FLOT protocol. It's a phase 3 multicentric trial, and we are participating in another sponsored trial, which is based on a dual HER2 blockade. One is the original and another is the generic. It's again a phase 3 trial, and we are in the plan of going first autologous stem cell transplant in collaboration with Department of Pediatrics and Transfusion Medicine in a Hodgkin lymphoma patient. And this is our we have started a DM program this year from January session, and we have conducted a workshop in November, and we have also participated at different forums in various CMEs which were conducted at our institution. Thanks.
Any questions, please? Comments?
Excellent. Really, things are changing so fast, and more often than not, many of the cases comes to the medicine and then goes to the medical oncology. As bifurcation, everything has emerged from the medicine, and you are doing a wonderful job, and definitely the care of the hematological malignancy, though we were treating before you came in a limited way, but definitely it has improved, and great boost to the AIIMS, and keep it up, and do well, and try to do the novel things, and definitely patient will benefit from your department. And Pramod is also doing the wonderful job. I know that is a high pressure job in Western Rajasthan, because there is a few centers and few persons are available. So don't feel pressure. Though we will pressurize, but you don't feel it. This is administrative things. Thank you.
Thank you, sir.
So excellent case workup and the presentation. Actually, if I can remember, there was one case also with the pregnancy with malignancy, and that patient expired. So I think during pregnancy also there may be a lot of challenges. This is also, we can compile all the cases of hematological malignancy during pregnancy. And also many new things, challenges can be overcome with like new technological advances and more index of suspicion and more broader workup. I think these cases illustrate that also. So congratulations, well done.
Thank you, sir.
I request all the faculties that those who have to present CGR and CPC, they must put on the AIIMS WhatsApp group. The person who is presenting can paste it 1 or 2 days in advance, because we put everything on the Dean Academic side, and they are also have a lot of pressure. So department will be, those who want to call all of us, they can paste it. Those who doesn't want to call, it's up to them. So please paste on the AIIMS Jodhpur, the department who is presenting, that what is they are presenting, so it will be easier for all to know. Thank you.